Yeah, thank you, Natasha, and everyone for this great discussion. And it's my role to introduce the next session that we call the metrics to predict clinical success. So we will discuss this morning before the lunch break the guidelines for immune analysis that we have developed, and I'm going to present. Natasha will give an introduction to imaging, and Teresa will discuss biomarkers. And this afternoon, after the lunch break, we will have an open discussion about these metrics and biomarkers. So let me try to share my screen. So we, after the last workshop 2 years ago, we started to think about how to help the community to perform analysis, especially for immunomonitoring. And we came up with these guidelines, which are recommendations. So I'm and Dr. Bullock is listed here at the authors, but because we led the effort, but we like to acknowledge the Cancer Immunotherapy Scientific Advisory Board of the Foundation and all the people who contributed when we published the guidelines for open comments. So the idea really is to propose some suggestions for analysis routes, for assays, for time points, in order to gather information on the temporal evolution of the immune response following focused ultrasound. And to try to really gather information needed to maximize the effectiveness of the treatments. The primary focus of the studies here are really to analyze the changes in terms of trying to develop a more immunocompetent or immunologically favorable, less immunosuppressive microenvironment, to try to gather data again to establish a rationale for combined treatment regimens, including focused ultrasound and agents with immunostimulatory effects, and to try to identify biomarkers. So that can be static, present at baseline, and that will help us inform patient and treatment selection, but also, of course, prognostic biomarkers that can be used to monitor the anti-tumor immune response. In terms of really general consideration, I will start with the second point that I should have put on first, that we really encourage people to do is to store samples. And we'll see how later, but the suggestion is really to run a few pointed assays analysis first, and then store the samples for later analysis that can be informed by following questions, patient outcomes, clinical data, and so on. Of course, all these recommendations are really general and will greatly depend on the drug used in combination therapy, and will be optimized and should be optimized according to the targets, to the tumor type, to the patient, and so on. And finally, the last general consideration is really, if possible, to try to implement flow cytometry for immune cell analysis. And this is a point we discuss also later, is that if you don't have access to these facilities or analysis modalities, we are trying to set up a core lab to perform this analysis. So we try to separate clinical studies from preclinical studies. And I think we discussed this during the workshop, and especially this morning. I mean, Dr. Lavallée discussed it again, that the emphasis here should be placed on a biologically primary endpoint rather than survival or progression-free survival in these clinical studies, because we are maybe not here yet. So what we want to do is to try to address fundamental questions. So are focused ultrasound associated with changes in the composition of the immune infiltrate, the phenotypes of T cells or myeloid cells, spatial distribution, infiltration, activation, exhaustion status, effect on the vasculature that we quickly discussed in the previous session, for example. And this will be guided by, again, by the disease types and number of samples available. We like also to emphasize, and this is something we discussed already during this workshop, the importance of windows of opportunity trials with an emphasis on neoadjuvant approaches, which will be a great opportunity to see a signal that before resection. So in terms of analysis routes for clinical studies, what we suggest is really to for tissue sample that hopefully can be pre-trial biopsy, on-trial biopsy, and sometimes resection, is to have FFPE samples for H&E, IHC, if possible, multispectral IHC, RNA-seq. Store samples, for example, in Trisol for future RNA-seq, or if you can disaggregate for flow cytometry and functional analysis. And the same for tumor draining lymph nodes when the samples are accessible, store or perform flow cytometry and functional assays and have FFPE samples. So what are we looking for? Well, I mean, we are looking for example, multispectral IHC for frequency and localization of what of CD4, CD8, Tregs, macrophages, MHC1, PD-L1, T-cell activation, phenotypic markers, cell death pathways, so necrosis, apoptosis, DAMPs, also something we discussed a lot. In terms of flow cytometry, then we can be more exhaustive in the in what we are assessing, so effector suppressor cell, APCs, suppressive immune cells, B cells, immune phenotype activations again, gamma delta T cells, and expression of immune checkpoints. For the blood samples, what we suggest is to, again, isolate PBMC and either perform flow cytometry on fresh sample or store in liquid nitrogen. Again, flow cytometry, RNA-seq, TCR analysis, ELISpot, and store plasma serum for a cytokine B-assay or circulating DNA. Here again, I mean, the question of the time points is really important, and something that we touched about during our discussions is that it's really important to identify the relevant time points to monitor the response to a focused ultrasound. For example, the peak of cytokine production, the peak of antigen release. And what we suggest in terms of time points, and again, these are very general considerations, is of course to have a pre-treatment baseline sample for in terms of tissue biopsy, and to have at least a sample at 2-3 weeks after the treatment when possible, when an adaptive immune response could have been developed. For blood samples, which are maybe more easy to access, we can have a time point at screening, a time point at baseline to make sure that the information can be reproduced. And again, at least have one time point at 2-3 weeks to monitor for an adaptive immune response. And also, we can look for circulating tumor cells and circulating free DNA. These time points, of course, will be informed by the drug that is being used, the dosing and treatment schedule of the first and of the drug, by the pharmacokinetics. We know that the response to immunotherapy typically occur mostly between the first and the third dose. For drug, the PK typically is max after 3-4 doses. So probably we can piggyback on the infusion, for example, schedule to gather blood samples, but all of this has to be informed by these characteristics. It's certainly also very informative to have access to a very early time points for blood samples to gauge the inflammatory response to focused ultrasound. So for preclinical studies, our recommendations are slightly different. It's really to design the study based on hypothesis. And what we would recommend is to start with a longitudinal study endpoint being overall survival. So when it's not possible, something that we discussed, for example, for subcutaneous tumors, sometimes it's not possible to ablate the whole tumor. So tumor growth control can be the endpoint, but first perform a study with this endpoint. If there is no improvement, then maybe run a selected assays to try to identify what the cause of the problem might be until we really have an effect of this overall survival or this primary endpoint. And then run some complementary assays to really demonstrate the involvement of the immune response. For example, running depletion assays, which can be CD4, CD8, or using the REG1 KO model, contralateral tumor control, metastasis control, and so on. And then run selected assays. So typically, I mean, CD4, CD8, IHC, or TCR clonality, and store the samples to further hypothesis-driven assays. We also like to emphasize the importance of reproducibility study. Again, something that we discussed yesterday. I mean, Dr. Frank emphasized, for example, the differences that you can have in the same background mice coming from different vendors. So it's certainly interesting to assess the effect across different tumor types, across different mice backgrounds, across sex, for example. And these are the flowchart that, again, you can find in our recommendation on what we suggest for the analysis. But basically, if you can analyze fresh tissues from tumor-draining lymph nodes, non-draining lymph nodes, spleen, flow cytometry, phenotype function, IHC, especially for spatial distribution, RNA-seq, especially for TCR sequencing. So in terms of summary, these guidelines are on our website. This is a document that is evolving to take into account all your comments. So these documents are open for comments. And to take into account the evolving technologies, for example, this kind of multiplex imaging that we can now perform. The foundation is really willing to support immunomonitoring in first clinical studies. So we like to really emphasize this point. So please contact us if you have clinical studies in the pipeline. We have work in progress to establish a partnership with Crest and Q-Square Solutions to establish a core lab. The idea being that in these clinical studies, you could send your samples to this core lab to have a homogeneous analysis of both histology and flow cytometry, and more genomics also might be included. And again, emphasize is really his recommendation to store samples, really important. So we have a few minutes to discuss, or maybe not, but at least this afternoon we will discuss the next steps. So some of the points that we discussed yesterday. So what is important now to progress? Is it for the foundation to support, for example, a suggestion from Dr. Lim, infrastructure for data analysis in terms of bioinformatics? Is it to provide support for data storage and data sharing? So this is something that is already available. So we have here a collection hosted by the Center for Open Science, where we are hosting the projects and data sharing. So it is not mineable so far, it's just data sharing, but this is the first step. Will it be to support sharing expertise and so creating a central facility for sample analysis, or more generally, create a collaborative multidisciplinary framework for analysis? So this is what I had to say. So is there any specific comment that you would like to share right now, or would like to discuss this afternoon? Otherwise, I think we will move to the presentation from Natasha on imaging. Oh, Tim, yeah, go ahead.
Just one quick question about the data sharing principle there. Is it anticipated that flow cytometry data will be able to store in that space?
Yes, so in this platform, so this platform currently is only for preclinical data. If there is an interest to share clinical data, we need to work on that to have the let's say more secure, let's say. And yes, so you can store any type of data. I mean, you can store some types of data directly on the server, but you can also link your project to your data repository on Amazon server. I forgot exactly what is the list of providers that are supported, but yeah, many types of data can be linked directly. Yeah. But again, this is not. So far, this is not Amazon, let's say, cloud type of platform. It's only storage of data. You cannot mine the data or process the data.
Oh, okay.
So this is the next step. This is the first step.
I'm looking forward to discussion about the bioinformatics options that you might be.
Sure.